for people who don't know what it is, what's the premise behind the Society of Metabolic Health Practitioners, and really what is metabolic health?
Yeah, so that's such a big thing, and it's what we decided to focus on instead of it being, because we wanted to create a society or a home for anybody that's open to this conversation, and and what we realized was it's not just about low carb, although predominantly that's the intervention that works. But what we're looking at is addressing all chronic diseases with dietary and lifestyle interventions instead of drugs, if possible, right? Or at least in conjunction with the drugs to make the drugs more effective and to hopefully be able to wean off them and not be dependent on them. I realized quite a while back with LowCarbUSA that we really needed to have some kind of a professional environment like this. And I started something on the Low Carb website, but I got, 25 people who agreed with me and paid the fees and joined up. But there wasn't enough of us to have conversations and stuff, to make it a really meaningful organization. And then Tro started putting out on Twitter at the beginning of last year, like, hey, we need to have a professional organization. And I wrote to him and I said, Tro, wait, I'm already doing this. Just it's not working that well. What do we need to do to make it more legit and make it where people are going to want to be a part of it? And he basically said, look, we need to have a real non-profit that is just focused on this and not on a bunch of other things that you also do, like in LowCarbUSA. So we started doing that. We talked about who we would want to have on the board of directors. I went out and learned how to create a non-profit and establish a non-profit, and we did that, put the board of directors in place, and then sort of commissioned someone to build a website for us. And we were hoping to launch at the end of November or the beginning of November. And we ended up launching in the middle of December. But so far it's been really well received. We've already got, well over probably 2,200 providers to put in.
I think one of the things that our community has been missing for a while is a place to organize itself. So I've been in and around the low carb landscape for about 20 years, which is a long time. And so I've seen, I guess I kind of got introduced to it. Can you hear me all right? It feels like the... Okay.
Yeah, at the moment.
Move closer to the internet. We have a big house, and so it's going through all these walls. Anyway, I sort of started working with Eric Westman, not long after Bob Atkins died. And Bob Atkins was the de facto leader of low carb for many years because he was. I mean, he had the book, he had all the things. And so when someone wanted to argue about low carb, they went to Atkins. But the problem with low carb at that point is that there hadn't really been any science done. And this is how Eric Westman, Jeff Volek, Steve Finney, Richard Feynman all sort of got brought into that circle and got to know each other by visiting Bob Atkins and talking about what kind of studies we could do to support this way of eating. Eric Westman discovered it when he had a patient. He was in smoking cessation, and he had a patient. So he would joke about how he would take his patients off cigarettes, and they would all just balloon up in weight, and he felt like he was just trading one risk factor for another. So he had a patient who lost weight instead of gaining weight, and he wanted to know how they did it, and it was Atkins, and so that's, and that's his story. But
Right.
what happened at that point was that with Bob Atkins' death, there was no clear leader for the community to rally around at that point. Richard Feynman and his Nutrition and Metabolism Society, he was sort of gunning for the spot. Eric Westman, I think, thought that he as a clinician should be the person. Steve Finney, who's an MD PhD and has both the research and the clinical side covered, he was a potential leader. There were the Eads, there were people all over the place, but it just nothing ever gelled. And this is Andreas Einfeld at Diet Doctor. He calls it our period of wandering in the wilderness. So low carb wandered in the wilderness for a while. There wasn't really, there weren't conferences. Now they're the Obesity Society of America, I think, but they used to be called the the National Association of Bariatric Physicians. Sort of carried the torch for a while. And the Nutrition and Metabolism Society used to have joint conferences. But basically, there was just no leadership, no community. Everybody was really siloed. And yet, all this work was happening. Volek, they were publishing studies. Finney and Volek published a great book, The Art and Science of Low Carb. And Will Yancey and Eric Westman at Duke were churning out studies proving this safety and efficacy of low carb. But there still wasn't a community. We were still just all over the landscape. And in 2010 or so, Bob Atkins began to be recognized as being ahead of his times because all this science was coming out showing that, low carbohydrate diets, and there was actually a dietary guideline committee somewhere in there where the committee actually said, we think this increase in carbohydrate consumption has contributed to the rise in rates of obesity.
Right.
And so that it became to be recognized that this is a safe therapy for people. But now, how do we promote it? How do we get ourselves together? So this is something Gary Taubes has been interested in for a long time.
Yep.
I've certainly been interested in it for a long time, watching, how the landscape has evolved. And in 2000, so right around then, 2015, 2014, I'm in a PhD program in communication, rhetoric, and digital media. And this is how I learned what Doug was just saying, which is that when you create a document, you're creating more than a document. You're creating a social world around that document, right? So when our forefathers wrote the Declaration of Independence, that's just a piece of paper. But what they created was a world around that document, a set of beliefs, a way forward. It was almost a map,
Right.
as much as anything else. So when Doug and I started talking about this standard of care and the sort of open mic opportunity to hear from clinicians about what they wanted, the clinical protocol just seemed obvious. We needed something that we could point to and say, this is us. This is what we do. This is what we believe. And it created a way for us to make that community around the document. Like Doug said, the document itself is not standard of care. But if we can point to that document and say, this is how we all try to learn, try to practice. These are the populations we practice on, that this intervention makes sense for. And it's not perfect, and he does things this way and she does things that way. But this is generally how we think about what we're doing. That creates a community. So we have the document, and we have this beginnings of this gathering of people, but we didn't have a home for them. And Doug realized, because he's brilliant, that LowCarbUSA was not going to be the right home, because therapeutic carbohydrate reduction is a lot more than low carb. and that those very words, low carb, sometimes turn people away before they can even learn what they could possibly learn. And so he chose the name Metabolic Health as the big umbrella under which we could all fit, because those of us who are in the know do know that the diet that is most obvious, that's most efficacious for metabolic health is one that reduces carbohydrate. So it makes sense. So we can, I don't think it's like a bait and switch kind of thing, which we've been accused of. Is this just LowCarbUSA rebranded? It's LowCarbUSA expanded. It's LowCarbUSA, and in which the word low means 100 grams of carbs a day or 20, right? It could mean either of those things. So low being a relative term is problematic. How low is low carb? And keto isn't much better. Like, do you have to be in ketosis to lose weight? No. Do you have to have measurable ketones to lose weight? No. None of that has to be true. We know so little about this. Anyway, it was the perfect place for these people who didn't have a home up until this point to point to and go, oh, this is, these are my peeps here. They believe in making sure that we're targeting the right things, that we're targeting normal levels of blood sugar, we're targeting normal levels of blood pressure, we're targeting body composition. We're not just targeting weight, right? And we're not just targeting a diet. We're not here to go, eat this way or you're doing it wrong. We're here to say, what way of eating is going to help you reach these health targets? And I think that's revolutionary for clinicians in general, not just clinicians who believe in therapeutic carbohydrate reduction, but for clinicians to say, what are your goals and how can we help you reach them is, and have a very patient-centered approach. That's not as common as it ought to be. So I think that this organization, it's really fun for me to be here, like, when it's just a little sprout, because I think it's going to be a great big giant tree one day. And we're here at the beginning, and it's really exciting, and getting to help shape how it'll grow. To me, it has so much promise because we've done it right. We haven't made this about a way of eating. We haven't made this about an ideology. We've made this about the patient, and we've made it about helping the patient live a long and healthy life in the way that they want to, not in the way that we think is best or right for them. Well, this is one of those things that, again, I think that Doug was brilliant in using the term because it's not well defined, right? So that means that somebody else hasn't already told us what it should be. It gives us room to say what we think it should be. And I'm going to show you my little schema. So we're starting with, our foundation is how we define metabolic syndrome.
Right.
So that's where we're starting with. And then we're adding to it, well, first of all, we're turning it into a positive thing, and then adding to it in a way that it includes things like body composition, which is not typically thought about when you think about metabolic syndrome or the opposite of metabolic syndrome. So that gives us something else to work with. I think what our idea of metabolic health does is it helps people think, do I have that? Do I have that? Do I have that? And Nevada Gray, who's a pharmacist, was really, really good about like helping us understand this needs to be something that people can evaluate for themselves in the comfort of their own home. Like not something that you have to go to the doctor to figure out whether or not you have metabolic health. So I thought that was pretty brilliant insight on her part. But it includes normal blood sugar, normal blood pressure, minimal abdominal fat, since we're learning more and more. I was talking about it with Mark and Brian this morning, that it seems to be like the measure that we can measure anywhere, anytime, and it really gives us a good read on somebody's health. Normal cholesterol and triglycerides, which we leave a little bit vague so that we don't have to get into the whole LDL argument with that, and then body composition that lets you be active. Right. Because if you've controlled all of these other things and yet you have sarcopenia, you don't have any muscle mass, you are going to have great lab numbers, but you're not going to be able to do the things that you really want to do. And we think that that's part of being healthy, is being able to do the things that you want to do. So that's how we're defining metabolic health. It'll probably be massaged and tweaked, but I think that it includes all of the important components. And of course, at least 4 of those components go back to insulin and insulin resistance.
Yes.
But because we don't measure that very often, we didn't want to highlight that. And I think we're still in a place where when you say insulin to people, they think of injections that people with type 2 diabetes get. They don't think of something in their own bodies.
Right, because your body creates it. Your body makes it. It's necessary.
Right, but then again, too much of a good thing is too much, right? And so this is where our problems arise. And how do we know we're having problems with our insulin? Well, our blood sugar goes up, our blood pressure goes up, our HDL numbers go down, and our triglycerides go up, and we begin to get fat around the middle.
So when you talk about belly fat, like that really is more like, I suppose visceral fat is not something that's as easily understood by, or often not properly understood. So belly fat's much clearer, but it really is beyond that. I mean, it's fat around all the organs, right? And then fat, including fat liver. I mean, Brian's become very focused on that whole thing of how important looking at visceral fat is.
I think it is important, and it's also neat because it's one of the easiest things to measure for patients. And I remember having patients, especially women, who would come in complaining that they hadn't lost any weight on the scale, and yet their pants were falling down. And we would have a tape measure. I have a tape measure. I still carry in my purse. It's my clinic tape measure, where you could measure the inches as they went away. And these women who had been lifelong dieters would have, skinny arms, skinny legs, sunken chest, and then they would have this little round belly like they were pregnant. So it was really obvious to me that abdominal circumference, that visceral fat, is really, really important.
Yeah, and again, as the weight starts to come off and the energy increases, they become naturally more active. They might not necessarily be specifically going and doing exercise, but they will be more active. They'll walk around faster. They will walk further because they can. And so that's going to talk about or result in muscles coming back that had atrophied before because they weren't being used. And so that's where that big thing where you don't see the difference in the scale, and yet people are so much more healthier and in such better condition than they were. And like you said, you have to find ways to point that out to them. Because most of them just look at the scale and that's all.
Yes, and it can be very disappointing if that's the case. But you're absolutely right. These women that we would have, they wouldn't even necessarily be more energetic or more mobile. Exercise was not something they did. They would build muscle getting themselves in and out of a chair. I mean, I would squeeze their upper arm and go, "You've got biceps now. You didn't used to have those."
Yeah.
And a lot of it is increasing protein. So eating. A lot of women are afraid of protein. I was having this discussion with my children last night that because they grew up in a very protein-centric household, and they were like, "Why would people be afraid of protein?" Because protein came with fat. And women believed, we were told, that fat makes you fat. And so we didn't want to eat protein because it had fat with it. And fat was going to make us fat. So we threw out the baby with the bathwater. And, what was the best source of protein that you could possibly consume? Boneless, skinless chicken breasts. And because you get protein and no fat. And so women just had a hard time getting enough protein. And I'd see women in clinic who had, they're eating 30 grams of protein a day. It's less than the RDA. And so when we re-fed them protein, their bodies just gobbled it up and made muscle. So I would say that if you can get your insulin levels checked, that would be great. But it is a test that they typically don't do in-house. You have to send out for it. It's not cheap, and your insurance company may or may not cover it. But the things from metabolic syndrome, blood pressure, blood sugar, and then HDL and triglycerides, those usually will indicate somewhere along the line that something is up with your insulin. And then the metabolic syndrome, and I don't remember the measurements right off the top of my head, but they do have, if your abdominal circumference is over a certain number, then that's indicative of having visceral fat or abdominal fat. I can send you the definition, but it's and those are good to use. There's nothing wrong with those at all. They also I'm trying to remember if they don't include BMI in metabolic syndrome, which is nice. Yes. But one of the things that's a little bit of an anomaly is that for people of certain ethnic groups, the high triglycerides, low HDL doesn't show up when you have high insulin. So it is possible to have very high insulin and not have any of those three things.
Symptoms,
That happens with African Americans. So they'll have a high BMI, they'll have a history of diabetes in their family, but their glucose is normal because their insulin's high. They might have high blood pressure, but since that's very common among African Americans, then nobody blinks twice about it. And then their triglycerides and HDL are normal because that's not a dysregulation that we see with metabolic syndrome in African Americans. So what we have is we have people who don't show up during screening as having metabolic syndrome and then have metabolic diseases. Some of the highest rates of metabolic diseases later in life. Whereas if we gave these people insulin tests, that would probably show up. We would see that. So it's just one of those things. It's not a foolproof method.
I know. I've heard Tro and Brian talk about getting an insulin test now relatively easy. I mean, it's not outrageously expensive.
No, you can get one yourself. I mean, you can go to LabCorp and order one for yourself.
And I mean, some people just don't have that money, and I understand that. But if there's a lot of people who can afford that, and if they're able to, I would, if nothing else, I would just go and have an insulin test done and start with that. Because if you got high insulin, you can guarantee there's a bunch of other things that can all go wrong with you.
Right.
If you can't afford that, then there's, there's other things that even just like a blood glucose testing thing. I mean, Keto Mojo does ketones as well, but I think you can probably get just a glucose tester for probably even less than, and the glucose strips are much cheaper than the ketone testing strips. So you could probably get, I'm imagining for diabetics and that you should be able to get a glucose tester, like a pinprick, and just see what your blood glucose is in the morning, and if it's way high all the time, that if it's way high, you can know that your insulin's going to be high, to be trying to keep that under control, and you know that you need to take things further, go to your doctor and start trying to understand how it is that you can fix this, and just go to our site and learn about if your doctor's not helping you, learn about what it is that's most likely affecting that, and search through the providers there and find someone in your area that can actually help you.
Yes, and if you don't mind poking yourself in the finger more than once a day, doing a before a meal and after meal pinprick to get your glucose is really good, especially if you do want to compare test meals. So do a breakfast with, bagels and toast and cereal and see what it's like after that. And then do a breakfast the next day with, eggs and cheese and see what it's like after that. And that can really be enlightening.
Yeah, and I mean, they're not available without prescription, at least not in the States yet, but the continuous glucose monitor is, and again, if you went with the Freestyle Libre or something and just took one, the one sensor lasts about 2 weeks, and if you just took one for 2 weeks, and now you can scan, you don't have to keep pricking your finger. I think everybody should have to do that, and especially all the doctors, because it is just mind-boggling how things that you eat affect your blood sugar, and that people don't understand until they see it for themselves, in front of them, on themselves, and it's like, oh, okay, this is maybe something I should pay attention to. That's more expensive and all of that, but hell, if you could get your hands on one, I would do it in a heartbeat.
Do you think that your organization is also works as a bit of a salve and help to practicing physicians and clinicians who are still under the umbrella of hospitals and administrators, and that this allows them to sort of like have some place where they can continue to learn and break free and maybe hopefully bring the knowledge and the experience that they're learning with them, because it seems like hospitals and insurance and all of those are very anti anything that makes a person well.
Yes.
I haven't heard it put like that, but that's actually kind of true. Adele, do you want to answer that first?
Yes. Well, I think one of the very special things about SMHP is that it gives us an opportunity to talk organization to organization, right? Whereas we didn't have that in the past. It was just a bunch of folks, and a bunch of folks don't mean anything. But if we can send a letter from a letterhead that says, our people would like to meet with your people, that's different.
Right.
And that's a huge lever to help move the ball forward in terms of, okay, so like we were just talking about, like insulin testing, right? If you had some SMHP practitioners who were finding this very helpful, and there's definitely literature on this, and they could show how patients that they were working with within a hospital were, coming in, and we measured their insulin and it's through the roof, and when we normalized it, we could send them home. If you get that within an organization, then you can have people come together, speak to the administration, and say, our organization believes that we need to cover insulin tests, right? Or we need to talk to insurance companies about covering insulin tests. So having an organizational voice is hugely important. So SMHP can now go to the American Diabetes Association and say, in your last clinical guidance, you talked about how lowering carbohydrate within any dietary pattern is one of the best approaches for addressing high blood sugar. But you don't have any material on your website about that.
Right.
Maybe we could help you train your members, your patients, your clinicians in therapeutic carbohydrate reduction, so you can take that principle and actually apply it.
And get people to actually start doing it. Don't just cover your backside by and that's half of the time I think that's what it is. It's like, okay, there's so much evidence there now that they have to make that statement. But like you said, if they really believed it, they would be pursuing it, and they would be publishing about it and having meetings about it and having their own conferences about it, but they're not. So that makes me feel that they're not actually totally on board with it. They just...
It's going to take a long time to turn that ship around. So I've been following the guidelines for about a decade now, and like clipping the little part on low carbohydrate diets and how it's changed over the years. And it went from low carbohydrate diets being categorically dangerous to them being acceptable for up to a year, because on day 366 you fall over, to now being one of the many options that you can offer to patients. So I think that the world is going to move in that direction, but, and this is where SMHP has so much to offer, is that clinicians aren't educated, dietitians aren't educated. We don't know how to do this stuff, and guess what? We are not going to recommend an option to a patient that we don't know how to implement. Isn't going to happen. So now clinicians can go to SMHP and get the training that they need in order to implement these interventions, and that's going to be a game changer. So one of the things that we're working on, Annette, is a presentation to other dietitians to say, it's really not that complicated, and you can do it too, and it'll be another great tool in your toolbox, or spice in your spice rack, which is how dietitians talk apparently, and give them the information that we have in a way that's welcoming, and it's not condescending, so that we're not going, the way you've been doing it is wrong, and you've been totally like almost killing all of your clients, and so now we're going to teach you how to do it right. We don't want to do that. We want to use diplomacy. We want to use very neutral language. And this is why it's not about getting people to go from eating what they eat now to eating 20 grams of carbs. So the little handout that I made just says eat more protein and eat more vegetables, eat less sugary foods, and eat less starchy foods. What is there to argue about, right? I mean, there's nothing wrong with any of that. But what it does is it shifts the attention to the foods that are good for you and away from the foods that you don't really need, in a way that's non-adversarial and non-controversial. No doctor is going to look at my little document and go, oh no, you should definitely be eating more chips and fries. So, but that's really underneath it all what we're talking about. You're getting rid of all the junk food, the ultra-processed foods, and you're focusing on the foods that provide the most nutrition. And if it's presented that way, you don't even have to talk about carbohydrate, right? You just talk about what foods are good for health, what foods are good for weight loss. Well, it's funny because bread doesn't really make the list in either of those places. Doesn't have a lot of nutrition. It's not going to help you lose weight. Why eat it? Well, we eat it because we like it. And that's a reason. But if your goal is to lose weight, or if your goal is to control your blood sugars, then you have to make different choices. So trying to remain sort of language neutral, and the term that we use at Diet Doctor is diet agnostic, where you're not aligning yourself with a particular dietary ideology, because diet, as you know, it's so political, and it's, there are these factions and the diet wars and all that. And we're really trying to move away from that. And this is, I think, by organizing around metabolic health, we really get to move away from that. Because it's not about a macronutrient. It's not about fat. It's not about carbs. It's not even about protein. It's about health.
Well, and your body doesn't know what calories are. It only knows what hormones are, and however you feed it, it's going to figure out a way to use it.
Or store it.
Or store it.
Or store it, yeah.